Thank you very much, and I guess it's very apropos that I'm doing this right as you're finishing lunch, and please continue eating as I do so, and it will be the main topic of my presentation. Obviously, yes, I've been very fortunate to become involved in a lot of projects dealing with pediatric pancreatitis research, certainly not the only one. Inspire was an effort by many, many, many people, including certainly Mark Lowe, who's in the room, and Aaliyah Uch, who is now kind of our main leader. So what I have no disclosures to make. What I'd like to do, and I'm going to have the clicker problems, I think. So I'll go through some things rather quickly, but obviously we all know we have to kind of speak the same language. So a number of years ago, we tried to make sure that actually that we are dealing with the same things. So when we deal with pancreatitis, it could be acute pancreatitis, which is going to be the most common way that we will see people. But you can have acute recurrent pancreatitis. We decided to call it ARP rather than RAP because of recurrent abdominal pain in pediatrics, which is a slight difference with how you might see it labeled in the literature versus adults. And chronic pancreatitis, which is one thing that actually Dave mentioned, that we can also think about it mechanistically. So it's probably more of a continuum rather than one single entity. So the first thing I'd like to go through is actually what is there out there regarding what we do with respect to nutrition in acute pancreatitis. And this is really the field where there is the most literature, as you will see. And although I won't go into great detail, most presentations are going to be mild, where people really don't have any organ dysfunction, although we know some people present with severe, and it mostly has to do with how long and how many organs are not functioning properly, and you end up in the ICU often. All right, whoops, I'm going to go back. So the first question became, why are we doing enteral nutrition versus TPN? And the history of using TPN goes back really decades, when it was realized that really sick people did better if they received some kind of nutrition. And so TPN became a mainstay at one point with really sick people. But then in the 1990s, a number of risks associated with TPN became evident, not only relating to biochemical, infectious risk, and other things. And so in the 1990s, this was the first kind of segue that it was shown through a number of studies that actually enteral nutrition was superior to TPN for acute pancreatitis. And this was even in severe acute pancreatitis. And since then, a number of studies, meta-analyses, some of these may have been shown in slides earlier on this morning, that really we should be using enteral nutrition as our standard of care and not TPN, as fewer complications and certainly actually benefits. Second question one might ask is, when do you start to feed someone? And this, again, when you go into the literature, I guess the planes are starting, we can talk about early, and variably in different manuscripts, there will be the use of whether you're talking about 48 hours or 72 hours, and even a few 96 hours. But let's say we're talking about roughly the first 2 to 4 days, we'll call it early feeding. And again, it's been shown in studies that if you feed early, you can actually have fewer complications than if you keep someone fasted. Now, how early is necessary? This is when some studies have also shown that actually probably you don't absolutely need to feed someone immediately in the first 24 hours. And a few studies showed that even if you fed them at 72 or 96 hours, they did very well, as long as then you fed them something. So in both the kind of the middle studies, everybody received something by day 4. So there wasn't a benefit particularly to get it on day 1, but everybody was getting something still relatively early on. And we know for mild acute pancreatitis is that the earlier you feed someone, they tend to stay in hospital less long, because you get to your endpoint of, oh, you're tolerating things, let's send you home. And it appears that even in moderate and severe acute pancreatitis, that feeding earlier will lead to shorter hospitalization. The location of the feed and the composition of feed also has been of great interest. And a lot of this is based on adult literature that I'm presenting. And it's become very interesting and much easier to manage, that the realization has come that you can feed in the stomach, in the duodenum, in the jejunum, and it doesn't make a difference. And that has made it a lot easier to insert feeding tubes that were sometimes very difficult to advance to the proper location. It's also been shown that, well, do you really need to start with clear fluids? And for mild acute pancreatitis, there have been some studies showing that if you start someone on a low-fat solid diet, they actually get more calories, it's safe, they don't worsen their outcome. And so, and even a full solid diet, if you compare it to a soft diet or clear fluid diet, with mild acute pancreatitis, you decrease the length of stay and you don't get more pain. So then, okay, what about, we put a feeding tube in, we're always wondering, should I be using elemental formula, semi-elemental, can I use a polymeric, which is usually cheaper to use? And again, it's been shown that even in mild or severe acute pancreatitis, there doesn't seem to be a difference in outcomes, so no absolute need to do this. What about, oh, I missed my cute little slide. Okay, so pediatrics. This is actually a field that thankfully now we're actually having some literature to support what we do in pediatrics as well. Obviously, these studies have to do with retrospective, mostly single center, but it's very interesting to see that we're seeing that you feed them earlier, you give them fluids, you let them take by mouth within the first 24 hours, people do well. One interesting study was that they had a historical cohort that the nutrition was dealt with by the medical team to decide when you let someone eat and whatnot, versus the next group was let the patient decide. And what it was realized is that patients know when they want to eat, and patients stay less long if you let them do what they want, rather than if you try to make a realization of, oh, is the pain gone down? Is the patient really ready to eat? So let them eat. And of interest for us in pediatrics is that although this did not deal with acute pancreatitis per se, there was a very nice study in the New England Journal that had to do with children in the intensive care unit. And what they showed, sick from a variety of different critical illnesses, obviously, is that it was better to keep people on IV fluids than TPN if they weren't having anything. And it was very much to their benefit if they received something in the gut. So always think about that. So maybe sometimes even giving TPN is not fantastic, and maybe actually being just on IV fluids with obviously glucose for kids might actually be better. So what do we have out there in the literature? A lot of recommendations obviously first start off with expert opinion, and then we hopefully have more literature to support it. And for acute pancreatitis, certainly this is where there's the most publications. This is from 2012 from Aspen. And obviously, we know we need to be concerned about people that have pancreatitis that will be at nutrition risk. Even in their publication, they said you probably don't really need any nutritional therapy if it's mild. If you're thinking you're going to be fasting for more than 5 to 7 days, you got to think about doing something. And we're talking about more enteral tube feeding, that we prefer enteral to parenteral, that you can use NG. They wrote a few extra things at the bottom that I think is much more expert opinion that I don't think we have a true outcome with as to whether you need to use different formulations or whether you need to supplement these formulas with particular additives. This is from 2013. Again, they kind of said oral feedings once the clinical situation seems to be getting better, that enteral tube feeding is key in severe acute pancreatitis, that you could do it NJ-NG. Everybody's kind of agreeing. Whoopsie. Whoops. And that parenteral nutrition really should be thought of as a second line aspect. DAGA, again, we said, okay, try to get, if you can, within 24 hours oral. If they're able to feed oral, you might as well do it as early as they want to. And that enteral is better than parenteral. And again, nasogastric, nasojejunal. I think we're all coming up with the same idea. Now, I was fortunate enough to be the lead for an effort between our pediatric GI Society in North America, so NASPGHAN, and our European sister society, ESPGHAN, where we went through the literature, what there is limited in pediatrics, also looked at the adult literature to try to come up with some recommendations that we voted upon that was published last year. And essentially, based on the limited literature in pediatrics and what there is in adults, we strongly feel the same kinds of things. Feed them. If the child wants to feed, let them feed. If they want to feed by mouth, let them feed. If you haven't been able to do anything by about 72 hours by mouth, you probably should consider a kind of enteral tube feeding. And that the NG is probably just as easy and much easier than getting an NJ in. And probably even in severe acute pancreatitis, oral, if the child will do it, is probably as safe. We don't seem to have any reason not to do it. We don't think that there's any need to have any special formula. We kind of left open that if you have a trauma to your pancreatic duct, whatnot, should you feed, shouldn't you feed? There's enough in the literature to really come up with a strong recommendation for this. And that we really leave parenteral nutrition when you can't do it enterally. And if you're going to use parenteral, try to use at least a bit of enteral. This will help probably with your bacterial translocation so that the combination of enteral and parenteral is superior to just using parenteral. So I think for pediatric acute pancreatitis, for adult acute pancreatitis, really feed it. If you can manage to feed it, don't use TPN. The second aspect I wanted to go through is the much more limited to zero literature that there is for acute recurrent pancreatitis. And this is to all fellows out there. There's a world of things that can be studied in pancreatitis, and this would be one of them. And really, when you think about it, historically, when people were kept MPO for a long period of time, then they went to a low-fat diet for a long period of time, and it was really unknown whether it was necessary. Now that we put people back on a regular diet much quicker, usually within a week, you're like, well, what are you going to do if they get a second attack? Are you then going to put them on a low-fat diet for the next several years? It's very difficult to know whether there's any need. The other thing is, it's actually interesting when you start to look at the literature, what in different countries they call low-fat versus ultra-low-fat. And North America and Europe is quite different in that. So how do you compare different things, right? Unless they actually told you the percentage fat that they were allowing people to have. There's no literature that you need low fat. I will put the big caveat, obviously, if you have hypertriglyceridemia, that you will need to be on low fat. But for other causes of pancreatitis, there isn't literature to support it. There's also been thoughts, do you need antioxidants? Do you need pancreatic enzyme replacement therapy? We don't have strong evidence that any of these are necessary. I couldn't find anywhere that there's an adult guideline regarding acute recurrent pancreatitis. We included it within our document because we were dealing with acute recurrent, and chronic. And we essentially, particularly in children, where obviously growth and getting enough calories and nutrients is exceedingly important, that we felt that we should support that children be put on a regular diet in between episodes. And that usually within a week of their attack of acute pancreatitis, they can be put back on a regular diet, unless obviously their triglycerides are an issue. That we don't recommend at this point that people get put on pancreatic enzymes in case they're having difficulty digesting, because we don't have evidence at this point that this is indicated. And similarly with antioxidants. So areas needing research. Thirdly, what I'd like to mention is where there's a little bit more literature, and which also becomes quite important because the amount of time that people can spend with chronic pancreatitis obviously can be years and decades. And obviously on the adult side, decades and decades. And then you go into the subgroups. Are you pancreas sufficient with respect to your exocrine function? Are you insufficient? Or do you have the very special type 3C diabetes that you can have with your chronic pancreatitis? Whoopa. So if you look at adult CP literature, the typical concerns are exactly this. Am I going to develop exocrine dysfunction, endocrine dysfunction? Will I have fat-soluble vitamin deficiencies? Are there other micronutrients, and in particular zinc, selenium have been put in the literature? Is somebody's pain so exceedingly limiting their intakes that they're not getting enough calories in? Obviously, there's a number of ways that you can look at this, whether it's nutritional measures, obviously weight, height, BMI should be an obvious. We always do it in pediatrics. I think it needs to be strongly, done in people who are followed for this kind of condition. In adults, I don't think too many people do unless they have helped the mid-arm circumference and triceps. And you want to get an idea of what's going on biochemistry-wise. Bone health is a very important issue. Even muscle components of sarcopenia has been, found to be a significant negative factor for people who have chronic pancreatitis. There's been research showing that vitamin A deficiency correlates with having malnutrition. There's a lot more low bone mineral density with people that have chronic pancreatitis, and in adults, it's worse if the person has alcohol history also and having exocrine pancreatic insufficiency. And in adult CP, it's suggested that people get screened every 3 to 6 months. Now, if you go on, the interesting part is we say, okay, well, they're pancreas sufficient. They should be able to eat regular food. But it seems that CP people have increased energy expenditure and increased resting energy expenditure. So they actually need more calories, even if it would be regular food. A lot of people have tried to modify what they're taking to decrease pain, and that can be increased MCT, decreased fat overall. There's no clear recommendations for PERT dosing in CP in adults. And obviously the addition of type 3C diabetes adds a whole different level of complexity. And these patients tend to be much more sensitive to hyper and hypoglycemias and more at risk of developing micronutrient deficiencies. So you need an organized approach. So this is from a publication dealing with adult CP, and you probably can't read all the details, but essentially the overall message is you need a team approach to this. You need to be thinking about what's going on with this patient, their diet, their measures on physical exam, their clinical symptoms, testing for their exocrine function, biochemistry kind of evidence of what's going on with the micronutrients, with the vitamins, the bone health, and then obviously lifestyle issues if there's smoking and alcohol involved. And you need all of this to really take care of a patient in the best way possible. If we look at children, again, we're always stuck looking at other literature to see, can we extrapolate? And there is a significant burden. A group in Poland has been following children with chronic pancreatitis, and they found that about a quarter of them had malnutrition. Our mostly North American, with one Australian and one group from Israel and Inspire, found that about 1/3 of CP children had been labeled as exocrine pancreatic insufficient. So this is significant morbidity that these children are dealing with. Unfortunately, there isn't a lot of information to go on. Obviously, we share a lot of concerns with our CF population, and I think we tend to take a lot of information from our CF children to try to see, can we help them that way? So, you know, what we do for our CF children, how often we screen them, how often we retest for vitamin deficiencies, what we do for bone health, and our PERT dosing, which is actually much higher per body weight in kids than adults do. We go up to 10,000 units of lipase per kilo per day. So again, any society recommendations? Well, our own society had said that we need to screen these children. We need to make sure we have validated measures so that we can objectively see when there's a problem. This should be done every 3 to 6 months, either, you know, obviously from the pediatric gastroenterologist or more of a primary care in the community. That children that have CP should have a regular diet for us. Again, calories are important. You don't want to limit their calories. And that you need to be especially careful if they also have type 3C diabetes. And that you should be checking their vitamin levels roughly about every 6 to 12 months. If you supplement, you've got to recheck what's going on with it. You have to be careful about bone mineral density in case there are issues, especially if they tell you on the history they're getting some fractures. And we're screening for exocrine insufficiency, usually via fecal elastase, probably every year you should. And our dosing, actually, when we have someone who's exocrine insufficient, we tend to push the enzyme dosing quite a bit more than the adults do. And then you check, obviously, if they're responding clinically. I'm running out of time, so I'm just going a little bit faster. There's actually some, very recently, the United European Gastroenterology publication that had to do with CP. So they actually also said malnutrition is common, that you need to follow normal eating if they're well nutritioned, that they don't want to limit dietary fat. I think it does limit calories, and it can lead to a whole set of problems. And that for most of them, they don't need feeding tubes and oral supplements, but that you need to be cautious about the fat-soluble vitamins. They go into more detail if you have complications of gastric outlet obstruction, which I'm not sure it's super frequent. And that obviously, again, enteral nutrition, when people are not able to take everything by mouth, is how you can help them have a better outcome in the long term. And they're at risk for osteoporosis and osteopenia. You got to check out to make sure they're not developing diabetes. The adults, the big children who have diabetes are also more complicated and more fragile, so you have to watch them a little bit closer. And the PERT is interesting, and I was mentioning this is, I think, a big discrepancy. In this publication, they mentioned 40 to 50,000 units of lipase for your meals and half dose for snacks. As I said, we tend to aim a heck of a lot higher for our dosing. And again, but what you're looking for in adults essentially is most of the time you're trying to limit the symptoms, whereas we in pediatrics are really trying to support appropriate growth, which I think has a much higher demand, that we try to absorb every last calorie that we can. And then obviously if you're not getting the response that you can, you try to move on a little bit more. So that's really what there is out there to help guide us. You know, a lot of it is expert-based, I have to say, and there's a lot of... We're going to have to start yelling. There's a lot of room to be left. Like, whether you're interested in the field of acute pancreatitis, acute recurrent or chronic pancreatitis, there's a lot of things that I think need to be understood. And this is really out for the fellows out there. There's a lot of things that can be done. Some of this research will take years. They'll have to be longitudinal. So if you start to get interested, this is the time to do it. And that's actually, as a segue, that's why I'm so happy to come to this fellows conference. I think it's so fantastic. And you've heard this message already from other people, that we're here as fellows that are in the field and that are coming back. We're so invested in wanting to make this a success because we all benefited from this. And it was such a pleasure to be here as a trainee, and it becomes such a pleasure to come back and hopefully inspire you to continue the field forward. So my summary take home, Whoopa. Nutrition in acute pancreatitis, feed, okay, just feed it. Pretty much with anything, probably within the first 3 to 4 days. Doesn't need to be immediate, but if somebody wants to feed by mouth immediately, let them. Acute recurrent, there's really nothing. Please do some research on this. And even for CP, we have to be cautious because sometimes they don't look necessarily that they're malnourished, but it's a much more longer term problem. And they're gonna have these issues for years and decades, so you have to try to prevent the deterioration before you end up getting into too much trouble. And that's it. Thank you very much.
We have a second or two for questions for Véronique.
Just a quick caveat from looking at the NAPS2 study and others. We sometimes get lulled into thinking that a person with pancreatic disease is well nourished because they're obese. And that's actually not true. They can eat a tremendous amount of sugar with no pancreas and get fat, but they will have malnutrition,
muscle mass and everything,
in other areas as well. So a systematic checking of all of the nutrition measures, as you pointed out, is important. Even if the person looks like they're overweight instead of underweight, it could be malnutrition because it's all sugar.
Absolutely.
Thank you. Anybody else?
So teamwork.
Comments? Yeah, Tyler.
I noticed lately it's been agreed, quote unquote, that gastric and enteral feeding are equivalent in terms of safety and toleration. But I still question that. You know, are we really adequately powered in the studies we have to not only see that they tolerate gastric feeding, but also that it doesn't really increase clinical severity, especially in patients with more severe clinical courses?
From what I've seen in the literature, it doesn't seem to lead to worse outcomes. Now, every publication that you look at, or certainly the recommendations that are out there from the different societies for how to manage, there's a caveat that obviously if somebody's not tolerating gastric, well, then you push the tube down further. It's possible, you know, we were talking this morning about discongruent results for fluid management. Maybe in a few years, somebody will come and show clearly that NJ is more beneficial to NG. So this may change. At this point, when we had reviewed, certainly for pediatrics, we had looked at also the adult literature, and we didn't find any strong reason to say that it was necessary that the tube be pushed down. Certainly for peds, it's a big issue. Kids tend to pull out tubes. So I don't know other people's clinical experience, but if we can get away with NG or by mouth, we try to do it that way. Yes?
So it's actually a sad thing that the NJ versus NG would not utilize the big NIH study because of lack of improvement. But when they eat RCPC and they say NG and NJ are same, in large volume of patients that I see, I started doing NG. This was way back. But most of the people just didn't tolerate NG. So for the last few years, we have not stopped a matter of NG. No RCPs, but
Yeah, so that's the caveat. We always say that's a defined print. Don't tolerate NG, put NJ. Yeah. Okay.
One of the things we found in adults is a lot of times if they don't tolerate feeding, it's because of the narcotics we're giving them for the pain, not so much for the pancreas itself. Do you have any data on how much narcotics are used in kids in Canada versus the US?
I don't think that's been looked at for acute pancreatitis in kids, how much narcotics. I don't know if anybody in the audience can tell me I'm incorrect. There's my Sam who will tell me.
So again, it's the limitation of being single center studies, but when we looked prospectively at our nutrition database and we fed the kids who had a milder course of pancreatitis, and it was really a pilot to look at pain as an outcome. So to shift the paradigm, we started saying, is it safe to feed children with acute pancreatitis? Because we had to really tinker the system. We were told, do not feed and rest the gut, but when the adult data came out, pediatricians still kept the kids MPO for days and days.
They still do sometimes. Yeah.
They still do. So we had to do a feasibility and a kind of safety study. So we started there and we said, if you feed the kids and let them PO and regulate on their own, their pain scores every 8 hours were assessed. The ones who were NPO compared to the ones who chose to eat were really similar. And then their length of stay was actually shorter if they ate, which made sense. In terms of the pain, even if they're required, so we have a very kind of an order set where you manage pain according to the severity. So you always start with an opioid-sparing medicine, and then if it's moderate or severe pain on the scale, because we ask the kids and show them the faces, then you've tried the opioid-sparing, they didn't respond, then you escalate the plan and you use opioids. So it's a very well thought of phenomena. So in that case, their pain tolerance was great. I mean, if you just don't start opioids off the bat, then you don't necessarily sometimes have to go for it.
You guys didn't end up, that was not published, that part of the opioid use?
I don't know
believe.
that we published
Yeah,
that in the
yeah.
initial
Because I don't think
series.
there's any pediatric data regarding whether enteral actually benefits with respect to using less. You know, because you don't get, or, you know, like it's a vicious cycle that if you're not using the gut, you end up.
Yeah,
on,
we just published
narcotics.
actually a few institutions together an algorithm to manage acute pancreatitis in children, and it includes those kind of pathways for what to do for opioid sparing versus then jumping to the opioids, helping to delay the problems of ileus or not cause it, because if you start with other opioid sparing, hopefully you would not deal with that, and then constipation part of the acute pancreatitis as well.
Okay, wonderful. Thanks for the discussion. Thanks, Veronique.